Thanks. Oh, thanks, Moira.
Thanks, Moira.
So welcome. I think we've got a really small group this time, so that's really great. We should be able to whiz through and then just ask anything you want. If you've got any questions, put them in the chat box, and Moira quite often just answers them before we even get to the end. If not, we can try and answer them at the end. There are a lot of slides, I'm afraid, because they're provided by National. I promise I won't be reading them out to you. We'll just whiz through them. Okay, so I'm obviously Kate Jones. I work across primary care and public health. My GM colleagues are going to put these actually online, these slides with your certificates, so you don't need to make notes, you can just download them. So just relax, listen, grab a coffee. Don't need your cameras on, just be comfortable. If anybody is sharing a computer, make sure you write your name and your email address in the chat, because otherwise we won't have you registered and you won't be getting a certificate. So we don't want to miss you out. So just make sure your name's on. Try not to touch the top of the slides where you get control of the computer, because it just causes us problems. Okay, so just have a listen. So make sure you've read this year's flu immunisation letter and also the amendment statement. It's actually been updated again this week, so keep your eye on it. Also keep your eye on the Green Book for any updates as the season goes along. So who we're immunising this season? We're offering vaccination to all children 6 months to 2 years in a clinical risk group, all children who are 2 and will be 3 on the 31st of August this year, reception children to year 6, years 7 and 9, and then any remaining vaccine will be offered to years 10 and 11 later on. Plus, we're offering all children who are living with contacts of people who are immunocompromised. The offer for adults 65s and over, all health and social care staff, and staff who are in contact with patients, and that includes your admin staff, your front of house staff. We're offering patients in any clinical risk group, and then from the 15th of October we're expanding the offer to bring in adults aged 50 to 64 who aren't in a risk group. Some of you today, this is revision, loads have done online training, lots of names are recognised and you've done this many times. So for most of you, it's just a quick bit of revision. If you are going to be using a PGD or a PSD, you need to have done the 2-day essential immunisation course sometime during your career. And the protocol, if you're using a protocol, that requires you just to be a competent vaccinator. Everybody that's vaccinating needs to be up to date with rhesus, anaphylaxis and safeguarding. Overview, I don't need to tell you anything about flu, you all know what it is. In an average year, an average flu year, about 8,000 people die in England of flu. Adults with chronic respiratory conditions are 7 times more likely to die if they catch flu compared to a healthy adult. And people with cardiovascular disease are up to 11 times more likely to die. We know that serious illness may occur in children under 6 months, pregnant women, and those over 65, plus obviously those with underlying health conditions. These groups are also at really high risk of severe complications like bronchitis, pneumonia, children with otitis media. Quick reminder for you that people may actually be in your clinics and transmitting flu without them having any symptoms. So make sure you look after yourselves. Remember ventilation, hand washing, masks. It wasn't just for COVID, it's for any respiratory condition at all. Make sure that you are keeping yourselves and your staff safe. So there's 4 types of influenza viruses, but we really are only interested in 2 of them. Influenza A is the most common, followed by influenza B. Both of them are highly contagious and their symptoms are similar. You can't tell them apart if you've actually got the flu. Influenza A is the type that causes pandemics. which is obviously a global spread of the disease. And the things you might have heard of would be bird flu, swine flu. And the A virus can cross between animals and humans. The influenza B viruses, they tend to cause epidemics, but typically they only affect humans, even though they can affect seals. There's two lineages of influenza B, the Victoria and the Yamagata. The influenza B viruses mutate much more slowly than the A. So when B's in circulation, it makes it a lot easier for us to second guess the flu vaccine accurately. Both viruses kill, both can send patients into ICU, and both often change each year. The World Health Organization does monitor the epidemiology throughout the world, and us in the Northern Hemisphere get all our information from what's happening in the Southern Hemisphere, who have winter before us. Each year, the World Health Organization makes new recommendations for the vaccine, and it's no different this year. We have got the vaccine is different from last year. So start vaccinating as soon as you can, as soon as you get your stocks in. You need sufficient time to ensure that we've got patients, a fair few patients vaccinated before flu starts circulating. It takes about 2 weeks for conversion. So we like to get them vaccinated really early. However, if you've got eligible patients coming in later in the year, you can vaccinate any time in the flu season. And the enhanced service specification this year allows payment for vaccines given up to the actual 31st of March 23. So for children, the nasal vaccine, the LAIV, and the QIVC vaccine are not licensed for those aged 6 months to 2. Eligible at-risk children are recommended to receive an age-appropriate inactivated egg-grown vaccine, the QIVE, if it's safe to have them. The QIVE will be centrally supplied for these children, and you should order them through the Inform website. The JCVI has advised that egg allergy children aged less than 2 can be offered the QIVC. It's an off-label offer recommendation. It is supported by data. It shows no inferiority at all. However, it is off license, so be careful which documents you're actually using to actually give the medication. You might be, if you're using a PGD, it won't be on there. If the nasal vaccine is contraindicated or otherwise unsuitable for the children who are 2 to 18, QIVC or QIVE can be given. QIVC is the first option. And again, QIVC will be centrally supplied for children and should be ordered through your Inform website. Children who are household contacts of severely immunocompromised people, for example, people that have had bone marrow transplants requiring isolation, should also be offered an inactivated vaccine, not the nasal vaccine. Eligibility this year, we've already mentioned this and we'll be mentioning it again later. The information is all in this year's flu letter. And as we're sharing these slides with you, I'm not going to read it out. Clinical risk groups are as you'd expect. Do remember that some patients who you know would benefit from the vaccine but have a disease or condition not mentioned are out there, and you'll be seeing them, and you can use your own clinical judgment. If you feel they would benefit from the vaccine, if you feel that a dose of the flu would be terrible for them, you can decide to give it using your own clinical judgment. That is absolutely fine. That disease or condition does not have to be on the list. Clinical risk groups, same as usual. I'm going to let you read it yourself. I'm not going to read it out. Again, clinical risk group for you to read at home at your leisure. So all pregnant women, including those who become pregnant at any time during the flu season, should be offered an inactivated quadrivalent vaccine, and that's regardless of their stage in their pregnancy. The vaccines recommended for use in pregnancy are the QIVC or the QIVR. If neither of these vaccines are available, and I do honestly think that would be really rare, you can use QIVE if it's safe to do so. Loads of studies have demonstrated that pregnant women can safely receive an activated vaccine during their pregnancy, and that their infants also receive some protection from the maternal antibodies. Women who become pregnant during the flu season, just give them the vaccine, no matter when they become pregnant. If it's in the winter, if it's in the season, vaccinate them. Timing of the flu season, usually we see a lot of flu around December to January. So we need to vaccinate as many as possible before then. But I have to say that this year, Australia has seen the earliest start to their season that they've ever had. So we don't really know whether we're going to get an early start either. Obviously, it's going to take 2 weeks to make a response to the flu vaccine. Pregnant ladies and their unborn babies are at really high risk of influenza-associated morbidity and mortality. So just vaccinate them as soon as you know they're pregnant. Breastfeeding, it's not an indication for a flu vaccine, but if they have a chronic disease or they are pregnant again, it's quite safe to give the inactivated vaccine to women who are breastfeeding. If you are actually vaccinating in residential or nursing homes, you can also vaccinate the staff whilst you're in there, and you will be paid for that. Again, for health and social care workers, there is an ability within the pharmacy and the GP contract to immunise health care homes, social care workers, if they have no availability to get to an occupational health. And I think that's really common in the care homes. There's no occupational health set up for them. You can vaccinate them, and also obviously make sure that you vaccinate yourselves and your team should you wish to be vaccinated. This is the figures of the flu vaccine uptake last year. I'm going to just leave that for you to read at your leisure. That's the children update, and again, I'm going to leave you to read that at your leisure. The uptake for our health and social care workers last year was pretty good. It was about 60.5% altogether. It's a decent number. Hopefully we'll get more this year, but it wasn't bad. So we've got the usual 2 types of vaccine this year. We've got the inactivated and the live attenuated vaccine, and that's the one given by the nasal route. We're saying that they can't give you flu. There is very, very slight chances, which we'll talk about later, but basically neither can give you flu. You get stories every year about somebody's auntie that had a flu vaccine 10 years ago, had the worst flu they've ever had and would never have one again. There's no way that it was the vaccine that gave them that flu. These are the flu slides and the poster of the flu vaccines available this year. Some nice information on there. Might be a slide that you want to take out, laminate, put on your wall. It's just handy to just be double checking you're giving the right vaccinations. So we'll look at the inactivated vaccines first. So this year, the inactivated vaccines contain 2 A viruses, and they are the H2N1 and the H3N2. And it also contains 2 of the B viruses. And as I said before, we've got the information for that from the Southern Hemisphere. The vaccine composition this year does differ from last year's. One of the influenza A's and one of the B's has been replaced. And obviously that's been based on intelligence from the Southern Hemisphere. Do make sure you're using this year's flu vaccine. I know that sounds bizarre, but I have been doing some public health audits in a few practices, and I have found some old flu vaccines in the bottom of fridges. So do make sure you've had a quick look and turfed out any old ones. You need to use this year's ones. So the adjuvanted vaccine. This is the vaccine we're recommended for 65s and over. And these vaccines have got a substance added to them that enhances the immune response made. It's been widely used in the UK for the past 4 flu seasons, and since we've been using it, the response in over 65s has been much better. So it's definitely first choice if the patients can have this. The cell-based quadrivalent vaccine, the QIVC, we first used this in the UK, I think for the 2019 year flu season, and this contains a whole inactivated virus. It's much more stable than the vaccines that we grow on eggs. After the vaccine viruses are grown, they're highly purified in the process to remove all of the cell culture materials, and this means that it's really highly unlikely that any cell culture remains in the vaccine, and that's quite important for some of our patients to know. The QIVR, this is a vaccine made using recombinant DNA technology. It doesn't require the use or growth of the influenza virus or use of any eggs during its process. And this means really that the antigen in the vaccine doesn't adapt or mutate, and it tends to remain an exact match to the A and B strains that the World Health Organization have recommended. So it's a really stable vaccine to use. The recumbent vaccine obviously don't use flu viruses or chicken eggs. Lots and lots of information out there this year, I've noticed, about this technology, loads of papers. If you do want to learn more about it, there's lots out there for you to read. However, I'm quite sure that everybody's really busy, and if you have any time, you'll use it for drinking tea. So the egg-grown vaccine, those of you that are as old as me will remember that this used to be the only one, really. But it's being used less and less often now because we have got better technology. It's no longer a first choice for many people, but saying that, it does have a place. So egg-grown vaccines are propagated in fertilized hen's eggs using healthy chicken flocks, and it uses the process that we've been using for vaccines for about 70 years. You can consider this vaccine for use in at-risk adults less than 65-year-old and pregnant women, but only if the first recommended vaccines aren't available. But do remember that QIVE is a recommended vaccine for children aged 6 months to 2 years in clinical risk groups if it's safe to give. Some of the egg-grown vaccines may contain residues of antibiotics, such as neomycin, so that is just something to check when you're checking allergies. So the nasal vaccine should be offered to eligible children aged from 2 to just up to 18, unless it's contraindicated. The nasal vaccine, the LAIV, contains an attenuated, which is a weakened vaccine virus, and it's been cold adopted, so it can't cause clinical flu. For children in at-risk groups for whom it's unsuitable, or for healthy children whose parents object to it, because it does contain porcine gelatin content, you can offer a QIVC. If aged 2 years to less than 18, when QIVC is unavailable, QIVE can be offered if it's safe to do so. So the nasal vaccine does contain pork. Nasal vaccine, great safety profile in children aged 2 to 18. Children that have this aren't at risk of passing flu to unvaccinated contacts. However, if they are living with people that are very immunocompromised, we do suggest that they are given inactivated. Being in the same room as a child being vaccinated doesn't increase your risk of catching the flu from them. If you're given this one, it hasn't changed. The nasal applicator is exactly the same as it was last year and the year before. Comes pre-mixed, ready to use. Remember, it does contain pork. It has got porcine gelatin in there that is derived from pigs. But it comes exactly the same as you've seen it before. Patients 65 and over, this year's offer in the first instance is the QIV. Second offer is the QIVR. Patients under 65 pregnant women, first instance offer QIVC. If that's not available, QIVR. So this year, for those people who are 50 to 64 who are not in an at-risk group, we are going to be starting to offer vaccines around about mid-October. I think the 15th of October has been recommended now. The QIVE, the egg base, is the first choice if it's safe to do so, but you have got the potential to offer QIVC or QIVR, but you don't want to be diverting your stock from clinical at-risk groups or those aged 65 and over. So if possible, it's going to be the QIVE. Flu vaccine for children we've discussed, but I'm going to leave the slide in for you to look at later should you wish to, a bit of revision. So there are a limited number of children who are very young and at risk who may need 2 doses of vaccine. These children are usually under the care of a secondary care consultant. Personally, I've never come across one of these children. I think a lot of them do get vaccinated in secondary care, but just be aware that there are some children who need 2 vaccinations. Usually the parents have spoken to the secondary care consultant. They know their children need the 2 and they'll chat to it about it, or the consultants or the specialist nurses will have let you know. I think a lot of them are immunised in the clinics. Every year, our researchers try to determine how well the flu vaccine has worked as a public health intervention. It is one of the biggest public health interventions that we do in primary care, notwithstanding that COVID was obviously bigger, but the flu vaccine is one of the biggest public health interventions that we do in primary care. Usually the primary care cover is between 30 to 60% for adults each year. The effectiveness for the children's vaccine tends to be higher. Last year it was 72%, which was brilliant. Remember that the kids who are protected don't go on to spread the virus. We do know that children are super spreaders. They wipe their noses, they wipe their fingers on the doors, they hold your hand, they sneeze on you. They're definitely super spreaders. And the more children that we get vaccinated, the less flu we tend to have circulating in GM. So there's really very few individuals that can't receive any of the flu vaccines. If you're unsure about a patient, give the GM immunisation team a call or chat to the patient's consultant. Make sure that you have read contraindications in either your PGD or your protocol or the Green Book. Especially if you're signing a PSD, remember that you need to look in the Green Book because you remain responsible. Don't give it to anybody that's acutely unwell. Children who are really snotty, well, use your clinical judgment. Quite often children remain with quite a lot of rhinorrhea right through the season. So you need to just decide whether it's a good time to give them that nasal vaccine or not. Inactivated influenza vaccines are contraindicated for patients who've had a confirmed anaphylactic reaction to a previous dose or to any of the vaccine components. The nasal vaccine, don't give it to anybody under 24 months or older than 18. If you're giving it to over 18s, it's off label. You shouldn't be giving it to any clinically severely immunodeficient children, and that's either due to the condition or to their treatment, to their therapy. Don't give it to children taking high dose of corticosteroids, so say prednisolone at 2 milligrams per kilogram per day for a week, or another example is 1 milligram per kilogram per day for a month or so. Never give it to children receiving aspirin, and don't give it to pregnant ladies. The nasal vaccine is not contraindicated for children living with HIV who are receiving the antiviral therapy and attaining viral suppression. They're quite safe to have it. Remember that I said that you mustn't give it to any children who are taking aspirin as a treatment. There's very few of them, but there are a few. But you do increase the risk of Ray's syndrome, so make sure that you do not give it to these children. As with all vaccines, there's a very rare possibility of any vaccine causing a severe allergic reaction, anaphylaxis. All people who are vaccinating, all of you need to be trained to recognise and treat anaphylaxis. Make sure that you're up to date with your training. And do make sure that you've got a kit available, a rhesus kit available. Make sure it's not down the corridor, locked in a cupboard. You need it out for your flu sessions. More information is in the Green Book. Have a read of chapter 6. There's lots more information in there. So the nasal vaccine isn't recommended for children or adolescents who are currently experiencing an acute exacerbation of their asthma. And that includes any kids that have got an increased wheeze or have needed an additional bronchodilator in the last 72 hours. Those children, just offer them an inactivated vaccine. And that's just really to avoid a delay in their protection. There's limited data available for children who require regular oral steroids for maintenance of their asthma or have previously been in intensive care for their asthma. So those children only give the nasal vaccine on the advice of their specialist. Those kids are obviously at higher risk from influenza. So if you're unsure, give them a suitable inactivated vaccine. So there's 2 egg-free vaccines available for this season, the QIVC, the cell-based, and the QIVR. And that one is indicated from 18 years of age. The other inactivated influenza vaccines do contain traces of eggs from the egg protein over albumin. The over albumin content of the flu vaccines is available this year on a chart which I've put in here, and you can just whip that out and have a look. So adults can be immunised using an inactivated vaccine with an over albumin content less than 0.12 micrograms per mil, unless they've had a serious anaphylaxis response to eggs. So I have put a chart in there so you can see how much is in each one. So that will be really useful for you to slip out, laminate and put on your wall. Egg allergy in children. So the JCVI have previously advised that children aged 2 years and over with an egg allergy, including those with anaphylaxis to egg, can be given the nasal vaccine. Okay, but there is an exception. The only exception is for children who have required admission to intensive care for a severe anaphylaxis to egg. And those children need to be either given an inactivated or given the nasal vaccine, the LAIV, in a hospital setting. Don't be doing it in primary care. Oh, that's my chart for your over albumin content. That's just worth whipping out and just keeping somewhere safe where you can have a look at it should you need to. Already mentioned, don't give the nasal vaccine to children on aspirin. Ray's syndrome has been reported when it's been used, so just be really careful about that. So the nasal vaccine isn't licensed or recommended for children who are less than 24 months, less than 2. We've done clinical trials, and children that have been given this who are less than 2 have had an increase in wheezing and an increase in hospitalisation. If you do inadvertently give it to a child less than 2, they don't require a replacement dose, but you need to have a chat to the parents. They need to be informed about the possible adverse events in the short term, that they may become wheezy, may need to go to hospital, and they do need to be advised to seek medical care if they do notice any changes. You can reassure that there shouldn't be any long-term effects from receiving the nasal vaccine. If these are children who need 2 doses, you still need to use the inactivated vaccine the second time. Obviously, if you do give the wrong one, you need to report it and you need to concentrate on lessons learned. If you inadvertently give the nasal vaccine to an immunocompromised child, you need to then assess the degree of their immunosuppression. If they are severely immunocompromised, you need to consider an antiviral prophylaxis. Otherwise, if you need to tell them that should their child develop flu-like symptoms, it's usually in the 4 days, the usual incubation period after the vaccine, they need to get medical advice. If you are using antivirals, either prophylactically or for treatment, then in order really to maximise the protection of that child, you need to be giving them an inactivated influenza vaccine, and you can give that straight away. So children who've had the nasal vaccine are known to shed virus for a few days after the vaccination. It's less able to spread from person to person than natural infection, and that's because the amount of virus shed after the nasal vaccine is usually well below the levels needed to pass on infection. And also that the virus that's used in this vaccine doesn't survive for very long outside the body. And obviously that's in contrast to natural flu infection, which spreads like wildfire. So we did talk about earlier on that you can't catch the flu from a vaccine. But there is a theoretical potential for transmission of live flu vaccine to really very severely immunocompromised contacts, and that lasts for 1 to 2 weeks following the vaccination. Most people who are severely immunocompromised, they tend to be patients such as bone marrow, are isolated, and hopefully they won't be near anybody that's had the nasal vaccine. But if there is a chance, give them the inactivated, give the child the inactivated. So exposure to healthcare professionals, I'm asked about this every year, lots of rumours out there. So the nasal vaccine, if you get it up a nostril, doesn't create a mist. It's absorbed through the child's nostril and nasal membrane really, really quickly. So if they sneeze straight away after, it's fine. It won't pass on. It's been absorbed. Theoretically, if you don't spray it up the child's nose and you just spray it into the air, could be transmitted. But there's been quite extensive research in the States, and so far nobody that's been in the room of a missed nostril has caught the flu. Saying that, severely immunosuppressed people shouldn't be administrating this vaccine, shouldn't be in the room, just in case. Vaccine ordering, you've already done this for the adults. Ordering the children's vaccine is via the Inform website. It goes out of date really fast, so don't book too many at once. Book, so get enough in for the next 2-3 weeks, that's all. Make sure that your cold chain is really safe. Store your vaccine correctly. Use the correct cold bags if you're on home visits. Read the manufacturer's guidelines. Remember, the children's nasal vaccine goes out of date really fast. Don't order too much at once. Data loggers, really, really worth having. If you do get a cold chain incident, it will give you loads of information, and it might be the difference between using your vaccines and not using them. They're not expensive, really easy to order online. They come really fast. If you've not got one in your practice, or you need to get one. That everybody should have them. So the legal frameworks for vaccination, really important to get right. There's a variety of vehicles to use, and we'll do a quick run through. Before we get there, just to remind you that home visits, every home visit for the flu vaccine needs to have a registered professional there. So your registered professional needs to be on all home visits. So we'll start with PGDs, very popular in primary care, used by practice nurses and used a lot in pharmacies. And most people are really used to using this. So the PGD allows a specified registered health professional to supply and administer medication without prescription. Only registered staff can use these. The document must be signed by both yourself and someone who deems you competent to use it, to use a PGD. So it doesn't have to be signed by a prescriber. It can be signed by your manager, but that person who's signing it is deeming you competent to use that PGD. If you work into PGD, you need to complete the full process of the immunisation yourself. You can't delegate any of the activity at all. Next, look at the PSDs. These can be used by non-registered staff who have completed their full 2 days immunisation training at some time in the career. So the PSD is an instruction to supply and administer a medicine that's been written or signed by a prescriber. So this one must be signed by a prescriber. It can be an electronic record made in the patient's notes, where each patient is identifiable to the prescriber. And what that means is that the prescriber must have assessed each patient, decided it's safe for that patient to receive that vaccination at that time. Now, the prescriber remains responsible for the whole procedure, and that includes your competence to vaccinate the person who's using the PSD. So you need to be sure that somebody is competent who is actually carrying out that duty on your behalf if you're the prescriber. The national protocol, I really like this. It's used quite a lot in the bigger clinics if you're doing sort of PCN vaccinations. Now, the protocol demands that a registered professional, and that's usually a pharmacist, doctor, or nurse, takes responsibility for the vaccination journey for that clinic. Both registered and non-registered staff can complete the process, but registered staff have to take consent. All staff involved must sign the protocol for each clinic, and a new protocol needs to be signed for every clinic you do. Now, the registered lead remains with overall responsibility for that clinic and right through the process, but obviously the other staff carry their own professional responsibilities as well. We've also got written instruction. You need to use this if you're doing peer-to-peer vaccination. Just download the template and then adopt it for your practice, and it needs to be authorised by a doctor, and that enables you to vaccinate your own staff. Occupational health, if anybody here is from occupational health, you've got your own documentation. I've been asked to tell you to check your insurance if you're doing peer-to-peer. There may be some extra insurance needed, but it's really straightforward and easy to sort out. And there is payment for peer-to-peer, not peer-to-peer, peer-to-peer flu immunisation. Now, the administration, the inactivated flu vaccine must be given in it should be given intramuscularly into the upper arm, okay, of those 12 months or older. If the babies, you can go into the anterolateral aspect of the thigh. Now, you need to be using the midpoint of the muscle for the deltoid, and you need to have the arm abducted at about 60 degrees. It's a really safe injection site, and it's really important that you vaccinate into the muscle to get the full absorption. The easiest way to find it is to put your thumb under the axilla, your hand across, and just inject straight across. Sometimes I'm really surprised where I've seen where vaccinations go. It does need to be in the right place. It needs to be in the muscle. If you're giving Shingrix and the AQIV, ideally it should be separated by 7 days, and that's really to differentiate the side effects. But if they're there and they're not going to come back, go for it. If you are giving 2 vaccinations at the same time, which you may well be this year with COVID and flu, try using different limbs. If that's impossible, the vaccinations must be 2.5 centimetres apart. It's really important, as I said, that you know how and where to vaccinate. If you're unsure, if it's been a year since you've been vaccinating, if you're new to vaccinating, speak to your locality training leads, get some more training, get some supervision. They will be really happy to help you out. Vaccinate in the wrong spot and you can cause problems such as deltoid bursitis, which is a bit like a frozen shoulder. You get poor absorbency of the vaccine, so they might get no protection, and you can cause nerve damage, pain. It's really easy to get it in the right space, so do take care. If you're unsure, just get a bit of supervision. It's really easy to get. Patients on anticoagulation, patients on warfarin, if they're in the therapeutic limits, the INR limits, safe to give. Patients with blood disorders such as haemophilia, often the best time to immunise is soon after their treatment. They've got a consultant. The consultant usually advises them when to get the vaccinations, but they can have the flu vax. The live nasal vaccine, obviously this squirts up the nose. It's not an injection, it's a squirt. Can be given at the same time as other vaccines. It's absorbed fast. Don't worry if the child has a sneeze straight after. So to give it, check the details on the syringe. Remember that it goes out of date really fast. So do check the date and make sure that the child is sitting upright. Just push the plunger with the syringe into the take the end off the end of the syringe, put the plunger into the child's nostril, and just press until the divider clip holds you. It's a really fast process. Do it really quick. Take the divider clip off, it just pulls off, and do the second nostril with the other half of the vaccine. I'm hoping that this year most of the children have forgotten how horrible the COVID swabs were last year up the nose, and it should be a straightforward, fast, painless experience for them. Sometimes if you can sort of advertise that this is a squirt up the nose and not an injection, it sometimes encourages mums to bring their children in. Common reported adverse reactions seem to be the same this year as they were for every other year. Inactivated, swelling, redness at the injection site, low-grade fever, sweating, fatigue, headache, usual sort of things. Sometimes small painless nodule forms at the injection site. That tends to be something that patients ring you about. It's not really anything to worry about, and most of these symptoms disappear in a few days without any treatment. Children having the nasal vaccine, again, the common reported adverse reactions are the same as usual. Nasal congestion, reduced appetite, temperatures, headaches. Now, rarely, and it is very rare, after either a live or inactivated vaccine, immediate reactions such as urticaria, angioedema, bronchospasm, anaphylaxis, it can occur. It's never happened to me, touch wood, and I've been vaccinating for years. But as I said before, always ensure that your emergency kit is up to date and it's really easily accessible, not locked in a cupboard. If you do have any serious reactions, always report it. Use the yellow card system. It's online. Anyone can use it. It's really straightforward. As with any patient interaction, always record all the details in the patient's notes using whatever system your service is using. Make sure that you record all the vaccine details and make sure you record your name. If you're vaccinated in the community and using paper records, that information needs to be fed back to the GP records as fast as is practicable. Needs to get in there online. Data collection is no different to last year. It's done in the background via IT systems. It hasn't changed. So the vaccine uptakes this year. So we do know that the Southern Hemisphere has had the worst flu year for the last 5 years. So we are keen to immunise as many eligible people as possible. Also, this year, we don't really know what COVID's going to do. Last year, you were run off your feet with vaccinations, but actually, you did brilliantly. Primary care did so well at getting people vaccinated last year. and I'm quite sure that this year will be no different. I'm absolutely certain that without us in primary care, that the whole NHS would break. I think that primary care is absolutely marvellous. Now, one of the reasons that we want to really increase our flu vaccinations year on year in the Northwest is that our population do face really stark health inequalities. Those in the most deprived areas can expect 18 fewer healthy years than those in the least deprived areas. During COVID, GM had one of the highest numbers of patients advised to shield due to chronic disease, which tells us a lot. Loads of our patients in the Northwest are already struggling health-wise, and in our sort of deprived areas, they're really struggling financially. This year, we do know that fuel poverty is going to exacerbate the relative risk of all chronic disease. Patients are going to be unsure whether they can pay for heating. They're not going to be eating properly. The risk of fuel poverty this year is it's a nightmare. It's a public health nightmare. As health practitioners, we do try and do everything possible to protect our communities, but I have to say that this year I am really worried about many of my patients. Can't do much about fuel bills, but I can slightly reduce the risk by trying to get as many as I can vaccinated. And I think that's how we need to look at it this year in the Northwest. Remember that children do super spread the flu virus. The more children we can vaccinate, the better it's going to be for our older population and for our population with chronic disease. Each centre should have a flu lead and someone with special responsibility for coordinating the childhood vaccine to coordinate your campaign. As I said, remember, the more children we vaccinate, the less flu we've got circulated in GM. If you are immunising children, be aware, as I said, that your flu vaccine goes out of date really quickly. Don't order too much at once. When you put your order in, it should arrive with you pretty quick, I'm told. So this year, don't forget to look after yourselves. Okay, you've had a really hard summer. Our summer this year has been like an ordinary winter, the amount of work we've had. The winter is going to be hard for us, so make sure you look after yourself. ICP guidance is still to wear masks when looking after patients with potential respiratory symptoms. All these people that come into clinics have got the potential to actually already have flu or COVID. Make sure you're using your masks, make sure you've got your windows open, make sure you are washing your hands frequently. If you or your staff can have the vaccine and wish to, make sure you get them vaccinated as early as you can. Make sure that you educate your front of house staff about the vaccine. Make sure they understand that this year it's even more important because of fuel poverty. We really do need to protect our older population and our people with chronic diseases. Most patients have a really good relationship with your front of house staff and they chat to them, and quite often they will listen to the front of house staff. Obviously they listen to you as clinicians, but make sure that your front of house staff are educated as well and know what they should be telling their patients. This I've just left in for you because it's some really good resources and it's just easy to have a look at the addresses rather than having to write them down. Again, some more. So all I can say now at the end really is that on behalf of public health, massive thank you for actually doing the flu campaign. Your day work doesn't go away. The flu vaccine is on top of what you're already doing. And I work in primary care as well. I know how busy it is, and I know how hard this winter is probably going to be. When we're given the flu vaccination, it doesn't just save lives. It also helps to reduce the GP consultations, the unplanned hospital admissions, pressure on A&E, pressure on the ambulance service. So every patient we vaccinate is going to actually improve all of those things, as well as hopefully stop them from getting the flu. So massive thank you for what you're doing. And I hope you don't have a really awful winter, but I think it's going to be a really busy winter for all of us.
Thank you so much, Kate, for that. A really interesting session again. We've got claps going on in the background there.
Thank you.
Has anybody got any questions while we're on with Kate? This is the prime time to ask her because you've got her full attention. So I'm sure you want to go home and read the slides. They will be available from tomorrow when you log on to the passport. Kerry's popped in any issues with the passport, who to contact. So if you, Amanda, if you go on the passport, the slides will be there to download from tomorrow. Usually takes about 24 hours for the certificate, but the slides will be available. So please log on to the passport and we'll get them done. So have a lovely evening, everybody.